Hey y'all, it's Amy from NBEO Go. I'm one of the optometrists that run NBEO Go. We both work here in San Antonio. We both work for ophthalmology groups, and I do think I may have used one of these drops to diagnose Horner's maybe one time in my career. So it is an important pathway to remember, but definitely important to know for boards. I thought it was one of my hardest pathways to remember. I got a lot of confusion between anisocoria and bright and anisocoria and dark when I was learning these pathways. So I wanted to dive into this early into your studying career, your studying journey, so you can watch it a couple times. You can play it back during your neuro section. And then I definitely recommend watching it a few days before board so it's fresh in your brain. So without further ado, we're going to jump into the Horner's pathway, the sympathetic pathway. We will do another video on, it's much shorter, on the parasympathetic pathway, the problems there. But this one is sympathetic. So Horner's is sympathetic, okay? So let's dive right into it. All right. So here we're going to be talking about the Horner's pathway. We've already talked to you about NBO Go. And the first thing we're going to go over is the different neurons related to the pathway, the sympathetic pathway to the pupil dilator. What that means is, as you can look on the screen, it starts at the hypothalamus and then it runs down all the way through the spine, and then it'll synapse right here at C8 to T2. That is called the first order neuron. And then as you look down, it'll jump to the second order neuron. It'll kind of dive down over the lung, come back up through the internal carotid, kind of wrap around the outside of it, but it'll synapse here, and that is called the second order. Each order is where the synapses are. And then the third order, as the last part of it, that synapses and runs to the pupil dilator and to the Mueller's muscle. So that let's dive into each one of those. The first thing that we're talking about is the first order neuron. So the hypothalamus runs all the way down and it synapses here. That first order neuron will synapse at the ciliospinal center of Budge. So that you need to know. And then if you're thinking about the location of this first order neuron, then think about what could cause it. I wouldn't spend time wasting thinking about memorizing this. I would just know if there's a location and that's where the lesion is. That's probably going to cause a first order neuron problem. The lesions in the hypothalamus, the lesions in the brainstem or spinal cord, demyelination diseases like multiple sclerosis, and neoplasms like glioma. Like I said, if you know where the location of the first order is, then you can figure out what problems could cause it. I would not waste time memorizing that one. Now let's dive into our second order neuron. And the second order just means it's already synapsed. It's the second axon running all the way down. So it synapses here, and then it'll go down over the apex of the lung, very important to know, and then back up, and it kind of comes with the internal carotid, and it'll synapse here at the superior cervical ganglion. The second order runs down from T2 over the lung apex, then up to synapse at the superior cervical ganglion. Now, what I would know is problems here. The best thing for you to know is Pancoast tumor. That's in bold here. That's a lung tumor. It's on the pulmonary apex. When it's on the tip of the lung, it can blow out the sympathetic here. So I would know Pancoast tumor can cause a second order Horner syndrome. Other diseases that can cause it are thoracic outlet syndrome, mediastinal tumors, and that's the part of the chest that's between the sternum and the spinal column. So think about car accidents or something, or even a tumor there growing, thyroid malignancies, and surgery. I personally would just know the Pancoast there. Now let's dive into the third order neuron, which is the last part of this pathway. It's already synapsed at the superior cervical ganglion, runs up through the internal carotid, does not synapse at the ciliary ganglion, and then it comes through to the pupil dilator and Mueller's muscle. So think about the third order. It's up through the neck and it runs along the side of the internal carotid, meaning internal carotid artery dissection could cause a problem here. It also runs up through the brain into the cavernous sinus. So any fistulas in the cavernous sinus can blow up the sympathetic system. middle ear infections, trauma to the base or the skull, and a vascular headache called a cluster headache. The two I would know here is internal carotid dissection, and then I would also know a cluster headache that's on one side of the head that comes with a miotic eye and ptosis. Think of a vascular headache called a cluster headache associated to Horner's, causing a third order neuron problem. Okay, now we know the pathway, and so I just want to dive into some terms. What does preganglionic and postganglionic mean? Anything prior to the superior cervical ganglion synapse is called preganglionic. So that would be first and second order. Postganglionic means that it's hit that last ganglion, synapsed, and it's the third order. So that's postganglionic. Now, a big thing that you need to know here is, does sympathetic pathway synapse at the ciliary ganglion? The answer is no. No, no, no. You do need to know the parasympathetic does synapse there. The sympathetic runs through the ciliary ganglion, but it does not synapse there. Now, let's dive into the signs. If you did have a lesion at any of these neurons, what could happen? And the way that we always think about this is the mnemonic that there's a unicorn named Pam, and Pam happens to be horny. Pam is horny, meaning Pam has a unicorn horn. Pam would be ptosis, anhydrosis, and miosis, meaning a small pupil. So if you can think of Pam, then you can know for Horner syndrome. Now, one thing I do not think will be on boards, but it's a unique thing to think about, is everyone always thinks of all three of these associated PAM as ptosis, anhydrosis, and miosis. Anhydrosis means lack of sweat. Now, technically, after a third order neuron may not have the anhydrosis because the split after the superior cervical ganglion, the sweat glands run down through the mandible and they don't go up the side of the face. So that is just kind of a unique tip there. Now, let's dive into something where we think, okay, I see a miotic eye, a small eye. I see a ptosis on this eye, and I see this side of the face is not sweaty. I think it's Horner's. And now what do I do to diagnose Horner's or figure out where the lesion is? The first thing we do is we compare anisocoria, the difference in pupil size, and greater in dark or greater in light. Meaning, in dark, the two different sizes between the pupil is bigger than it would be in light in this situation. So let me kind of dive into that and kind of explain it a little bit more. Meaning, I test the pupils in regular room light. Then I turn the lights off and retest the pupil size. If the difference between the two pupils is bigger when it's dark in the room, then it's more likely a sympathetic problem, because the eye that is supposed to dilate in sympathetic problem cannot dilate, so it stays small. On the other eye, the normal eye, its sympathetic fibers are working, so it gets bigger. So now in dark, there's a difference, a bigger difference between the two. One eye could be 8 millimeters and one eye could be 3 millimeters, because the eye that was supposed to dilate could not dilate because there's a sympathetic problem. Now, in an opposite term, anisocoria greater in light is a parasympathetic problem, like 80s tonic pupil, because the parasympathetic problem says we've shined a bright light on the eye and it can't constrict. So the two different size is bigger in light in a parasympathetic problem. We're going to deal with anisocoria greater in dark because we're talking about the sympathetic pathway here, meaning I test the pupils. The right eye is 4 millimeters and the left eye is 6 millimeters in regular room light. Now I turn the lights off. The right eye stays the same because it can't dilate. So it's 4 millimeters and then the left eye is 8 millimeters. That means the difference in dark, the anisocoria is greater in dark. So that has to be a sympathetic problem like Horner's. It can't dilate. Here is an example. If you have regular room lighting, the right side has a ptosis It has a miotic eye, and then this is a normal eye. Then we go to dark, and it stays the same, but the pupil that's functioning fine gets bigger. The Horner's eye cannot dilate on the ipsilateral side, so it can't get bigger. So the difference between these two here is bigger than in the regular room lighting. So that means the anisocoria is greater in dark, which is a sympathetic problem. Now, okay, we've confirmed it. We said the anisocoria is greater in dark. Now what? We in fact need to make sure it is Horner's. And the way that we confirm Horner's is with apraclonidine or cocaine. I'll say that again. We're confirming that it is Horner's. We use either apraclonidine or cocaine. And the way that apraclonidine works is you will see a mnemonic in just a second. Apraclonidine causes a reversal, meaning when you look at the patient normally, there's a small eye versus the normal eye is bigger. When you put apraclonidine in, it'll actually dilate the small eye, and that's the reversal, and it will not dilate the normal eye. So the small eye now becomes big, and that's why it's called a reversal. The reason apraclonidine works is because it upregulates alpha 1 sensors, which it normally would do alpha 2 and constrict. When there's a problem, the alpha 1 takes over, and that becomes the dilator, and it'll dilate the problem eye. So apraclonidine causes reversal. The small eye now gets big. Versus cocaine can also confirm that it is Horner's, but the cocaine will take the normal eye and it does not dilate it. So the problem eye will not dilate. So what this says is causes the normal eye to dilate, but the problem eye will not dilate. It stays miotic. So in apraclonidine, the small eye becomes big. In cocaine, the small eye won't dilate and the normal eye will. And the way that works is because it blocks the reuptake of the norepinephrine in the synapse. So here, I'm just going to pause for a second, and this is the mnemonic for you. So think about the mnemonic. We're trying to confirm. It's confirming that it is Horner's indeed. And the way that we confirm it is we use apraclonidine or cocaine, or we don't use them at the same time. And this mnemonic will help you remember that. Confirm a PAMR, meaning C is for cocaine operates by norepinephrine fence, so it blocks the norepinephrine. On the ipsy side, it remains miotic, so that spells out confirm. Cocaine remains miotic. That's the biggest takeaway. Then the A stands for apraclonidine, ptosis, miosis, everything reversal. So you need to know cocaine and apraclonidine are the confirmations. You choose either or. The cocaine eye will remain miotic. The apraclonidine eye will do a reversal. It'll take the small eye and make it big. Now, like we were talking about, aniso and greater and dark, here it says confirm a sympathetic problem. And the way we're confirming it is using apraclonidine or cocaine. If there is a sympathetic problem, apraclonidine will dilate the miotic eye, but not the normal eye. If it is a sympathetic problem and you use cocaine, cocaine will only dilate the normal eye, but not the miotic eye. And so this is a really good key for you to look at, that the way to confirm it is apraclonidine and cocaine. All right, now what's next? And now we've said, okay, now we know it's Horner's. So then we have to wait a couple of days and bring them back because you have already dilated them. So now you need a day where everything's out of their system. And okay, we know it's Horner's. How do we figure out in the location, in the isolation of it, where the order is? Is it a first order problem, a second order problem, or a third order problem? What you'll do is you'll put on a different day and you'll bring them back and put in hydroxyamphetamine. So again, apraclonidine and cocaine are going to confirm. Hydroxyamphetamine is going to locate. It's going to tell us which lesion, where the lesion the problem is, and which order. So we're going to finish off our little path here. We've found out that it's anisocoria, greater and dark. We now need to confirm that it is a sympathetic problem. So we instill apraclonidine and cocaine. And then we found out that it is Horner's. So now we put hydroxyamphetamine in. And if the first order or second order has a problem, the meiotic eye will still dilate. So you put it in because it has not affected the superior cervical ganglion. The first or second order means I put hydroxyamphetamine in and that small eye gets big, then that means you have a first or second order Horner's. If you put hydroxyamphetamine in and there's no firing, that means that their last part of the pathway doesn't work. So it doesn't dilate, and that would be a third order neuron problem. So again, the third order neuron, because no signals are coming after that last synapse, that means there's a third order problem. Now, here's the mnemonic for you to remember. It says, where is it? WHERE. Where means you have to wait a couple of days. You can't do it on the same day. The H is the key here. Hydroxyamphetamine encourages the reuptake of epi, and the initial secondary, the ipsy side is titanic, meaning the first and second order, same side, is big. What that means is if you see a titanic, a big pupil, it's dilated. It has to be the first or the second order. If it does not dilate, then it has to be the third order neuron. We hope you enjoyed this video of Horner's. And if you ever want to take a peek, Dr. Jan Bergmanson, I did my fellowship with him, is a brilliant man and has done the anatomy books, the ocular anatomy, and lots of research. And his diagrams are the ones that we used. And so his reference is here. And then if you want to check us out at nbogo.org, we're a nonprofit organization promoting ways to study for boards because we found that there was not a lot of tools out there for optometry students. And it's a way that we sell 7,000 flashcards to help students to study on the go. So if you enjoyed the video, please feel to check us out here. Thank you so much. Have a great day.